Now? Hi, everyone. Welcome to our Global VMR. We have a very special session for all of you. I'm really personally excited about this session. We have friends from Germany and Austria who will soon introduce themselves and walk with us through a case. The point of these sessions is to really get to know our colleagues more, learn a little bit about the differences and the similarities of medicine and clinical reasoning around the world, and of course, really dab into what I love the most, which is like culture, food, music, and all of the things that makes us who we are. We actually started this group a couple months, maybe years ago, with Shema. She was like the pioneer who started translating schemas into German. And we can like put it in the chat so that everybody can take a look about like the wonderful work they do. We have a bunch of schemas in German available for everybody. And that really made me get to connect with Shema and then with everybody else. And I truly love all of them. So excited to get to know more about you. Shema, do you want to start?
Hi everyone, I'm Shema, and currently I finished my 5th year here in Berlin, Germany, and I've been loving doing all the work with this German team here with Sammy, Leah, Anita. It's when I realized like now over 1 year that everything started, and I've learned so much and also grown so much with all of them together and with all of you, and I can't be more excited to discuss a case with you and also to talk about, clinical reasoning here in Germany and Austria. And before talking too much, I would lead the way to Sammy.
Yeah, thank you, Shema, and welcome everyone. I'm Sammy. I'm so glad that I see a lot of familiar names and also German familiar names. We also have a small group where we always discuss cases in German, and I see Daniel is here. Matthias is here, Julius is here, Alex is here. We have a lot of people also joining, and yeah, I'm very, very happy to be here with you all. And Nicola has a case for us in store today. I, Shema, and Leah know the case, but you can really, it will get deep into it. So yeah, can't wait what you think about it. And I would hand the mic over to Leah.
Hello, everybody. My name is Leah. I'm also a medical student from Austria. I study at the same university Sammy studied at as well. And it's just such a privilege to be in this space and now also kind of share not only the international space, but also some who share the same language and have them in this VMR today as well. I also see Aman, who's joining us, and I'm sure many more who I haven't maybe seen now in the video yet. And yeah, I'm excited to discuss medicine, but also culture with you. At the moment, it's funny because I am from Austria, but I'm currently in Germany because I'm doing an exchange internship here. So I'm really at the border of the two at the moment. And I want to give the mic to on to Anita to introduce herself as well.
Thank you, Leah. I'm sorry, my voice is a bit hoarse because I've caught a cold, but I'm still able to speak. Yeah, I'm Anita. I'm also very excited to join the case discussion. I have studied, I actually recently graduated from the same university Shema studies in right now. So yeah, that's also how I came to CP Solvers, and I'm very excited about this format. It's not only about, I guess, not only about medicine, but also about discussing Germany, Austria, and yeah, I'm originally not German. I grew up and came to Germany when I was 17. I'm originally from Russia, but I've been living in Germany for like almost 8 years now, so I can also contribute my part to that. And I'm excited for Nicola's case. Nicola, would you like to take over?
Yeah, sure. So I just love to say hello to everybody at this very special global /German/Austrian VMR. And Hallo an alle, die sich aus Deutschland und die aus Deutschland und Österreich heute da sind. My name is Nicola. I'm actually a final year Croatian medical student, actually just a few weeks away from graduation. But I have had the great honor and privilege of spending the last 2 years of my medical school in Germany, in Austria, Graz, where I of course met all of the amazing people that make up the German/Austrian section of the clinical problem solvers, and they really took me in with open arms as one of their own. So it's been a pleasure discussing with them and talking about clinical reasoning with them. So yeah, I'm just very excited to be here today, and I'm bringing you a case, which was actually a case from Abakar Mugamedov, who is unfortunately not here today with us. And who, because he's at work, he's a resident at Charité, at the University Hospital in Berlin. And Abba is just such a legend, and he's known for his amazing cases. So hopefully I'll be able to present the case as well as he did. And I guess we can start the case now, right? Okay, I guess if the
sure.
are ready.
I think we can start.
Okay, so we have a 79-year-old male presenting with upper abdominal pain and weight loss. And let me just give you a little bit more of the background. So the patient was in his usual state of health up until 4 weeks ago, when he started having upper abdominal pain with concomitant fever and night sweats. He also developed slurred speech and dysphagia. Which has made eating and drinking difficult for him. And he also lost about 15 pounds of weight in the same time period, which would be about 7 kilograms for all of our European friends here today.
All right, I think we can stop here. Please feel free to share your thoughts in the chat. What's going on? What are your first thoughts? We'd love to hear them. Yeah, and we really want to make that interactive. Also unmute and share your thoughts. Yeah. Ibrahim is already having a good idea. I don't know, you want to unmute yourself and share your thoughts, Ibrahim?
Yeah, sure. So I think when this case first started with upper abdominal pain, I was starting to think about organs that could localize to the upper abdominal area. But then when you further saw the dysphagia and the slurred speech and the loss of weight, it all started to look into more of an inflammatory neoplastic process that I'm wondering if it had started in the upper abdomen and is now presenting systemically.
Yeah, very important point. I think in this older age, it's very important to think about malignancy. Yeah, also this dysphagia is intriguing. What do you all think about the slurred speech? Or maybe Shema, what do you think about when you hear slurred speech?
So when I basically think of slurred speech, when we think of our neuro VMRs, we have to differentiate, is it something like aphasia or dysarthria? So dysarthria more of a lesion within the cranial nerves, and aphasia when there is any kind of brain lesion due to a kind of a stroke. But it's still very unspecific. So any kind of so the most important thing for me here with the slurred speech and the dysphagia is maybe there could be any kind of process within the throat that hinders him to speak. I think so that at the moment that's very unspecific for me. I'm sorry, Sammy, I didn't expect that you would ask me.
Oh no, that's perfect. And Hans had a very good point about the esophagus and the dysphagia. Would you like to unmute yourself, Hans?
Yes, my first thought was, let's approach the abdominal pain because it's in the upper area anatomically, and that would look more like the stomach. But then when dysphagia was mentioned, this means he has trouble swallowing food and liquids, but it does not involve pain. I think odynophagia would be pain. And then I thought about something maybe at the intersection esophagus, stomach, where he might have a growth, or he might have something pressing from outside. Either would be possible. If we assume a malignancy, just it's a little bit far-fetched at this point and we don't know, then we could assume a hypercoagulable state with a thrombus being from somewhere getting into the brain and then causing a stroke, but all of this is still vague.
Hans, I just want to intervene a little bit. Do you want to introduce yourself? Because this is sort of your VMR too.
Yes, I grew up in Germany. I actually studied pharmacy over there. I came to Canada because they needed pharmacists so badly. And then I ended up in med school. And now I graduated as well from med school. So when I joined VMR a long time ago, and I just find it fascinating. I've learned a ton from all these sessions. And of course, the schematas.
Amazing. I still remember the first days when I just watched the VMRs on YouTube and didn't even join live, and Hans was always a constant there. Yeah, great. I think if Maria, unless you want to say something, I would say we do the next aliquot. Are you okay with that? Perfect. So Nicola, please go ahead.
Great thoughts, guys. It's always amazing how many things you can put together with just so little information. So I'm going to give you guys a little bit more about this patient. So past medical history is significant for a diagnosed mycosis fungoides. This was diagnosed about 2 years ago, and it was initially treated with methotrexate and interferon alpha. However, the patient then developed a Sézary syndrome, which prompted therapy with mogamulizumab. And with the treatment with mogamulizumab, remission was achieved. The patient also has been diagnosed with prostate hyperplasia. A squamous cell carcinoma of the lower lip, which has been treated with a resection. The patient also suffers from hypertension complicated with a hypertensive cardiomyopathy. Atrial fibrillation is also known and is treated with a left atrial appendage occlusion device, as well as bilateral glaucoma. And I can also give you guys a physical exam if you want to.
Yeah, go ahead, Nicola.
So as for the vitals, the vitals are significant for a heart rate of 130. We have a mean arterial pressure in the 60s. We have a mild initial hypoxemia, which then rapidly corrected to a saturation of 99%, which is on 2 liters of oxygen. And as for the temperature, I have no exact readings. However, the patient is definitely having episodes of high fever. The patient's pupils are around equal, reactive to light. Mucous membranes are dry. The cardiovascular exam was only notable for an irregular tachycardia. otherwise normal S1 and S2 sounds without any murmurs. His lungs are clear. There is some mild abdominal distension, but the rest of the abdominal exam is totally normal. The patient has no rashes, but on inspection there is severe bilateral leg edema. And on neurologic examination, the patient has a GCS of 15 and is fully oriented, speaking, however, with a slurred speech, but without any focal neural deficits. So, what are your thoughts?
Yeah, thank you, Nicola. So now that we have this quite significant past medical history, I'm curious if anybody has thoughts about how this changes the way we think about it. Is there something that is now you prioritize it more, or are there new differentials coming up? Abby, yeah, Anita?
Sorry, did I? So my main differentials are he is experiencing B-symptomatic, as we say in German. I think it's, I don't know if there's, I think there is a term of that in English, like it is fever, weight loss, and night sweats. He has all of it. So my esophageal cancer, abdominal, gastric cancer come to my mind, or also cancer in the esophagus of the pharynx also is possible. What I would ask him is if he has regurgitations or if he doesn't. So that's my first differential, like cancer. Also, what I think of as hematological, because he has T cell carcinomas which have been treated, but that leaves him immunosuppressed. So what I think next is esophagitis, which also can express itself as pain, weight loss, and what he's presenting with, plus fever. So I would test him for, I would do endoscopy. Sorry, I'm thinking in German. And I would also do blood cultures just in case he is already becoming septic, to exclude that possibility. Yeah, so that's my thoughts.
That's amazing, Anita. And I just want to say that, like, we encourage everybody to say the words that come to their mind, even if they're not in English. It's always amazing how people think in so many different languages in here, and then we need to translate to English. But thankfully, this community always helps out with the translations. So please don't apologize for it. That's why we're all here. And I wanted to prompt you with a question to learn more about, like, the epidemiology of Germany and Austria, because whenever I hear B symptoms and I'm in Guatemala, I definitely think of TB before malignancies. What type of malignancies do you see, like, more often in your patients?
I think that all of the from all of the malignancies of the GI tract, the colon carcinoma is the most common. The esophageal carcinoma in Europe is actually declining. The stomach carcinoma as well. I think in Asian countries, esophageal carcinoma is getting more often. But in Europe, it's actually declining. Yeah. But it's still, like, TB is not the first thing we would think of. Not if he's immunosuppressed is another question, but in the normal patient that we would just treat as a GP, you wouldn't think of TB.
Amazing, super helpful. I'll pass the mic to Sammy and Shema.
Yeah.
Sorry.
Sammy,
go on.
Shema. No, I was just thinking. Okay, I was just thinking, we have a map around 60, so this patient is clearly hypotensive, right? And the heart rate of 130 is also really alarming. So it seems that we have some kind of shock going on. When you see a patient in shock, what are your first thoughts? What's management-wise you want to do first? I just started residency 2 months ago, and when I see this, I first want to see what is the heart doing. So get a quick ultrasound, check are there signs of obstruction or other kinds of signs of cardiogenic shock, and fluid load the patients if they tolerate it. Just also think about Rx over Dx. As Reza always says, sometimes it hurts us to say that, but yeah, we are clinicians. So yeah, what are your thoughts about this shocked patient and patients? Yeah, I think Abi mentioned in the chat the history of AFib increasing. Maybe Abi, are you in a place to unmute and share your thoughts with us? If not, that's no problem. I can also read your comment. Doesn't seem. Yeah, Abi was saying that the history of AFib can increase the chances of stroke, causing the slurred speech, and could also predispose to mesenteric ischemia, and that's totally fair game. He's also having the abdominal pain, although it's more in the upper abdomen, but yeah, patients present in a lot of ways. Patients can present atypically. So yeah, definitely a good point. Yeah, I don't know. I think due to time management wise, I think we should go to the next aliquot because we have a lot more in store for you.
Amazing discussions, guys. So I'm gonna give you the labs. So we have a white blood count, which is at 1.5. We have a hemoglobin of 10 and platelets at 28,000. We have a sodium of 143, chloride of 112, a BUN of 39. We are with a creatinine of 1. Glucose is at 50. ISD at 250. ALT at 86. Alk-Phos is at 360. Total bili is at 2.7 and albumin is 2.4. I also have an ABG for you guys. So the ABG showed a pH of 7.36 with a PO2 at 88. So this is with those 2 liters of oxygen. We have a PCO2 of 27 and a bicarb of 15.3. And also we got an elevated lactate level at 9.5. The LDH is at 29,000. C-reactive protein is at 110 with a procalcitonin of 1.3. And we also got a basic coagulation study revealing an INR of 2.3 and an APTT of 170. The fibrinogen was also unmeasurably low. And also, as a quick side note, the patient is not on any anticoagulation for his AFib since he has the occlusion device installed. So those would be the labs.
Amazing, aliquot. Thank you, Nicola. And I've seen so many people in the chat mentioning the pancytopenia, and there are also already amazing thoughts like how to connect also like kind of the dysarthria, dysphagia. Yasmin, would you like to unmute?
Hey, hello everyone. Yeah, the first thing that came to my mind when we all started seeing pancytopenia and all this past medical history of Sézary syndrome, mycosis fungoides, think, well, this person may have something, may have this, may be prone to these issues, malignancy, and has dysphagia, dysarthria. And so far, one of the blood malignancies that can cause it is the large B-cell lymphoma. And although I'm trying to look for the article where I read it from, but I will be sure to share it with you in the chat.
Thank you so much. And I also see, Dr. Ravi, you mentioned something about the hyperlactatemia, and also the metabolic acidosis was mentioned. Can you tell us a little bit more about it?
Oh yeah, no, I was just emphasizing that when you have a lactate greater than, as you, when you follow the curve that you have, Paul Marino's ICU book, if you look at that, there's a very nice curve in there, and lactate less than 2, the mortality risk in type A hyperlactatemia is almost near 0. But as you go from 2 to 4, exponentially it increases, and you jump from, say, 20-30% mortality risk to probably 50-60. And as you get closer to 10, mortality risk due to type A hyperlactatemia may reach close to 90%. So this is a gravely sick patient, and makes, I guess, everybody's worried on here. So identifying a very sick patient is one very important task that we all have to commit to. Back to you.
Yeah, amazing thoughts, Ravi. I was also thinking, so we have this pancytopenia now. What else is remarkable in these labs? When I saw these labs for the first time, I was like, wow, the glucose is 50, the lactate is 10, and we always talk about the way of proportionality in clinical problem solving. And yeah, the LDH of 29,000 is like really like sky high. And I have 5 things I always think about when I see a very elevated LDH. First, you have to think about cell turnover, but most importantly, you can start with white blood cells. Is this a lymphoma? Is this a leukemia? And that's like rapidly having a high turnover. Secondly, are those RBCs that are lysing, for example, if you have marked hemolysis, you can also get LDH elevation. I don't know if it can go that high, but that's also something I'm always thinking about. Third, I'm also always thinking about infarcts. Is anything getting infarcted? For example, kidney infarcts, splenic infarcts, pulmonary infarcts, all can increase the LDH. In certain scenarios, I'm also always thinking about PJP is also notorious for causing an LDH elevation, especially you have the right set, have to be immunocompromised and have HIV or are on glucocorticoids. And one last thing I'm always thinking about is like other cancers with a high turnover, for example, germ cell cancers, for example, seminoma and non-testicular cancers can also have very elevated LDH. So yeah, I don't know. Did anyone moderate the chat? I was talking.
I think one thought that came up several times already, which I thought was really interesting, was the diagnosis of a tumor lysis syndrome with the elevated LDH. And Laura, do you maybe want to share what other labs might help you get information about that diagnosis?
Yeah, with the tumor lysis syndrome, you would expect some of the electrolytes like calcium and phosphorus to be abnormally high, I believe. I'm trying to think back to the textbook here, but I believe there's a third one as well that would be affected. I'm not recalling at this time, but yes, yes, or low. Okay, so hyperpotassium. Okay, yeah. So just I didn't see those labs dictated, but it'd be interesting to know them.
Yeah, great thoughts. Thank you for sharing that. I think we're ready now to continue with the next aliquot, Nicola. If you mind sharing that.
Sure. Great thoughts, guys, as always. So what I have for you are some imaging. So including some CT scans of the head, chest, and the abdomen. So the head CT was actually totally normal, so normal brain parenchyma without any lesions whatsoever. The chest CT showed bilateral pleural effusions, as well as opacities in the left lung, specifically in the lower lobe and the apex. And it also showed multiple bilateral mediastinal and pulmonary lymph nodes, which were enlarged. However, no signs of pulmonary embolism or any pericardial effusion. the CT of the abdomen showed a large lymph node conglomerate in the left retroperitoneal space, measuring about 2 by 4 inches, as well as multiple and large lymph nodes in the peritoneal, as well as the retroperitoneal space bilaterally. We also see some hepatomegaly and splenomegaly, as well as some ascites. And I also want to give you guys a bit more of the labs. So at this point, an extensive viral hepatitis serology was performed, which included serology for hepatitis A, B, and C, as well as herpes simplex virus, CMV, pyrovirus, Epstein-Barr virus, and all of those came back negative. Also, a whole autoimmune hepatitis serology was sent, including antibodies such as SLA, SMA, the ANCAs, LCMA, and AMA, also which all of them came back as negative. We also got a haptoglobin, which came back as unmeasurably low. We got a negative Coombs test, and a peripheral smear showed no schistocytes and no blast cells. So I'm going to leave you at that.
So we now have so many new things that have come with this aliquot. And as also mentioned in the chat, I've seen so many amazing thoughts in the chat, especially what Dr. Ravi mentioned, that he was assuming kind of a DIC pattern. As I see, we once had a VMR. If we see pancytopenia and DIC, were two things that we always have to think about. It's APML that can present with DIC or tick-borne infections. But in this case here, we have, like, as I see now, mediastinal lymphadenopathy and also retroperitoneal, and we have this low fibrinogen, pancytopenia, very low haptoglobin. What kind of thoughts? Oops, I think my laptop. What kind of thoughts you have? I see especially Austin had some amazing thoughts, and I would like to ask him whether you could unmute.
Oh, sure. Can you hear me? Yes. Okay. Yeah, no, I think this is an amazing case. Thanks so much for bringing it. But whenever you have someone with a history of malignancy, you're always thinking to yourself, is this related to their cancer? Could it be related to the treatment of their cancer? And it's always, there's a great hematologist at UT Southwestern that had cancer himself, and he always used to say that when a patient with cancer comes to the clinic with a headache, it's not just a headache, right? Every time you have any symptom, you always think about your cancer. And so I think whenever we see patients, that's the lens how we should approach them. But now we've encountered so much more data. We have the pancytopenia, we have confirmation of diffuse lymphadenopathy with an inflammatory syndrome, and I think this increases our concern for either a transition of his cutaneous T-cell lymphoma to something more aggressive, or maybe this could be a manifestation of the disease. I honestly have no idea, because I've never personally seen, I've seen only one case of cutaneous T-cell lymphoma. And then we think about other types of lymphoma that can have transition to more aggressive disease. I believe they call it like a Richter transformation. Someone can correct me. I don't recall. It's been a long time since I've studied the hematology, but I think all these pictures together make me concerned. And then with the inflammatory syndrome and then the edema, Kirtan had like a really nice episode where he discussed how edema can sort of be a part of some of the histiocytic aspects of certain diseases like Castleman's and HLH. So those are the things that came to mind. But I'm really excited to learn more and hear more about this case.
Wow, thank you so much, Austin. Those were such brilliant comments. And Hans, you also had an amazing comment in the chat. You maybe want to unmute yourself and share what you were thinking.
I don't know whether I have anything new. When Austin mentioned HLH, I thought we might as well do a triglyceride and have more evidence for this. Otherwise, my thought was, when I saw those lymph nodes, it looks very much like a lymphoma, but still at this stage, I don't know. But we are going for one of those lymph nodes and dissect it if we have time enough. Because pathology needs time and the patient needs treatment.
100%. I think you're totally right. Yeah, Nicola, what happened next?
So I can give you some more labs. However, this is the final aliquot before the final diagnosis is made, before all of the biopsies come in. So I'm going to give you a little bit more information. Lumbar puncture was performed at this point, and it came back as totally normal. Serum ferritin levels were elevated at 22,000. Serum triglycerides were elevated at 650, as well as a soluble interleukin-2 at 60,000, the normal range being about 100 to 500. So I'm gonna leave you at that.
Thank you, Nicola. So I just want to take a step back and just acknowledge how complex this case is. And if your head is spinning by now, I think you're not the only one. I'm sure many of us feel the same way. Now that we have so much information, how do we decide what is important? How do we summarize this? I think with the problem representation, it always helps to take a step back and try to get a clear picture. So I will try. I haven't done or prepared this. I will just try it right now and see what comes. But I would summarize this as this being a 90 or 79-year-old male presenting with 4 weeks of constitutional symptoms, a past medical history of hematologic malignancy, now with unstable vital signs, pancytopenia, and elevated inflammatory markers. And so how would we kind of take this to the diagnosis? What is on your differential? I think I know many in the chat are now mentioning HLH. Jasmine, do you maybe want to share how you would summarize this? What is, for people who might not know HLH, what makes you think of that? And share that with the group if you want to unmute.
Of course. So I believe that this should be an answer perhaps, but for me, the diagnosis of HLH, if there is a criteria, if I'm remembering right, that there should be fever, splenomegaly, cytopenias that should be affecting 2 of the 3 lines, being white blood cells, red blood cells, or the platelets. There should be, and I don't remember the levels of each one. I think for hemoglobin is less than 90 grams per liter. I really don't have the levels right now. Hypertriglyceridemia and or hyperfibrinogenemia. I cannot say that in English either. And this, the next step would see if there is any process in bone marrow, spleen, and lymph nodes, and as well see if laboratory, how the natural killers are acting, and the ferritin. The ferritin is very, very important. In this case, more than 300 or 500 of ferritin. Again, I'm so sorry for the levels. And there is a marker that, if I'm not wrong, is CD25 that we should see if it's higher than 2000. I'm pretty sure that those are the criteria for HLH. But one of this patient has this pancytopenia, he has hypertriglyceridemia, he has these B symptoms pointing us towards malignancy. So I think the next step would be a bone marrow biopsy or a spleen and lymph node. I don't know what the chat says.
Amazing. Thank you so much for sharing that almost very complete list. Yeah, I'm wondering how we should proceed if anybody wants to unmute and try problem representation in German. If, I don't know, Aman, I wanted to ask you, just feel free to say no if you don't want to unmute. Otherwise, I'm sure Sammy or Shema are also happy to jump in. But do you want to try or not? Just feel free to. If not, then we can, yeah?
You have to explain again what exactly am I supposed to try?
Oh, I'm sorry, I didn't explain that. You're right. So it's the problem representation. How would you summarize the case, and then we can try to do that in German if you want. So, but if I just realized, since I didn't really explain this, it might be not well prepared. So I would ask Sammy maybe.
Maybe it's
if
better
you want.
because I made some notes and I tried to find one cause for all of this, and my mind is like this. So I think it's better if Sammy tries.
No, you're way too kind, Aman. So just what is a problem representation? And I learned that from Reza, like I think 4 years ago when I started listening to CP solvers. So it's composited out of 3 things: the who, the when, and the what. And first you have to think who is the patient? What is the epidemiology? Is he immunocompromised? Does he have a history of cancer? What are his exposures? Is he taking any medications? Stuff like that. Then the second thing is the when. What is the time course? Is it more of a chronic? Is it acute and chronic? Is it acute or is it hyperacute? And that's also very important to also frame your differential and then think, yeah, that's more likely, or a different thing is more likely. And the third thing is what is the clinical syndrome? What are the signs? What are the symptoms? Are there any associated symptoms? And when you have these 3 things, you can say, yeah, this is my problem representation. And going on from that, you can then say, those are my top 5 differentials for this problem representation. And that's also very important to always do that and always re-evaluate your hypothesis and check the new data that you're getting. And yeah, I can maybe try that in German if I messaged some people that I know if they want to do it, but somehow, yes.
I think Shema has one.
Oh, Shema, yeah, please go for it.
It's a very short one that I wrote. It's basically, wir haben eine 79-jährige Frau mit B-Symptomatik, Hepatosplenomegalie, Panzytopenie, Hyperferritinemie und einer Vorgeschichte für kutane Lymphome. Genau. And I would also like to read out the problem representation that Alex wrote because I love it. So we have a 79-year-old male with a history of mycosis fungoides and Sézary syndrome that presented with subacute fevers and dysphagia and was found to have fever, hypertension, and tachycardia in the context of diffuse retroperitoneal lymphadenopathy, hyperferritinemia, and a high CD25 concerning for vasophilic shock in the setting of secondary HLH due to new versus recurrent of hematologic malignancy. Yeah.
Whoa, and just so that I can listen to something fast that I can actually understand, Hernan, do you want to unmute yourself and read it in Spanish?
Hola, ¿cómo están? Sí, yo lo escribí aquí en el chat. Mujer, adulto mayor, que se presenta con shock en el contexto de un cuadro subagudo de fiebre y compromiso multisistémico, digestivo, cardiológico y del sistema nervioso central, en el contexto de antecedente previo de micosis fungoide. Los exámenes muestran compromiso hematológico predominante compatible con signos de compromiso de médula ósea, pancitopenia, LDH elevada, ferritina elevada, además con triglicéridos elevados, todo lo cual habría que concluir que tiene, ¿no es cierto?, un síndrome hemofagocítico.
Yay, thank you. Should we wrap it up, Nicola?
Maria, can I do the Farsi version?
Oh, what did you say, Reza?
Can I do the Farsi version of the problem representation?
Please. Yeah, go for it.
First, I just want to thank everyone for such an amazing session. You guys are just incredible. Just so much to soak in there. ولی این مریض 79 ساله یه مرد که قبلا دیاگنوز لیمفوما رو داشت الان اومده با HLH. Bon chance. I put a little French at the end.
I only understood HLH.
Me too.
All right. I think we can go forward.
All right, guys. So I have the biopsy, and a liver biopsy was made, which showed denser infiltrating lymphocytes with occasional hemophagocytosis. Of course, also biopsies of the lymph nodes and bone mark biopsies were made, and together we can make the diagnosis of a diffuse large B-cell lymphoma, which was then complicated by a hemophagocytic lymphohistiocytosis, HLH. And yeah, that's basically it.
Whoa, I just want to say this was an amazing case. Nicola, I know that you were nervous at the beginning, and I kept thinking about this phrase from David Sedaris. He was a New York Times comedian, and he had a book, and he travels to Germany, and he's trying to pick up some phrases in German so that he can use in his trip. And he writes, "Ich kann do this." And I kept thinking, together we can. How did it feel to present a case to such an international audience?
Well, I mean, it was amazing. I'm out of words. I don't know what to say. Just amazing discussion. It was great to have this really global community here, all discussing this one case. I don't know, amazing.
Yeah, and we also want to thank you, Nicola, for putting this case together. I know how much work that can be, and you presented it so brilliantly. And I don't know, I think you haven't presented yet on VMR, but that's hopefully not the last time you present. And yeah, thank you so much in advance. And what are maybe two points you took away from this case that you maybe want us to remember from this particular case?
Yeah, sure. I would maybe just comment upon a few concepts which I took from this case. So the thing with HLH is that it's not actually so to say a real diagnosis, in the sense that once the diagnosis is made, the reasoning is done. The next question is actually always what is driving that HLH, and the causes can be roughly divided into autoimmune disease versus viral infections like CMV, EBV, or cancer, such as in this case. Also, let me just comment on that high ferritin. I think it was also mentioned in the chat. Once you get above like the range of 5,000 or 10,000, the differential diagnosis gets actually really short, which can help you in a difficult case like this. I think I like to think of it as either HLH or adult onset still's disease can do such a high ferritin, as well as histoplasmosis or hemochromatosis. I'm sure those are not all of the diseases, but the list is not that long as well. Maybe just to touch on that very high lactate, I think Ravi also mentioned that with waving Marino's ICU book. If you have a patient with a lactate that is so elevated, you're not going to be able to speak with that patient. That's also something that Abba, when he presented to us, spoke about. If it's a type 1 lactic acidosis, the patient is going to be in the ICU, probably intubated, but this patient was fully oriented. So it had to be another cause of this lactic acidosis. And I would just comment on the Warburg effect, which is, the lactic acidosis that can be a consequence of anaerobic glycolysis in cancer cells. And I think those are maybe just a few points.
Yeah, thank you so much. It was so intriguing, right? I don't think we said it, but the patient got fluids and his lactate still didn't get better. So it still stayed around 10 to 8. And then also the hypoglycemia was intriguing. And that also pushed the treating clinicians more like, is this maybe a B cell population that is digesting like glucose not the way it should digest it? And that also resulted in the suspicion that there's maybe more concern for lymphoproliferative disease. Yeah, thank you so much for presenting this amazing case, Nicola. I don't know, maybe we can talk a little bit about Austria, Germany, Switzerland. Yeah, I don't know. I met CP Soros like 4 years ago, and then I was like always in the back for 2 years, only listening to the podcasts, watching VMRs on YouTube. And then like 2 years ago, I think I first presented my first case. It was a case of severe hyponatremia to RLR. I think only Ravi was able to do it. Reza wasn't there, and I was so nervous. And that was like 2 years ago, and now I'm here with all of you together. And I just want to highlight this amazing community that we have, and just invite you all to come join us every day. It's really an amazing group of people, and especially highlighting Shema, Leah, Anita, and Nicola. And we also have a lot of friends here from Austria and Germany that somehow are a little bit shy to unmute themselves or show them. Aman is here. Yeah, but I would maybe hand the mic to Leah and Shema.
I have a question for Aman so that we can hear a little bit about her. And it's an easy one. If we ever go to Germany or Austria or Switzerland, and I know it's a big space, but what should we eat? That's our favorite question. We're all foodies here.
You know, actually, I'm from Germany and now I'm living in Austria. So you would expect that I could recommend a typical German dish or Austrian dish. But usually I like to eat Asian food or pizza. But when I came to Austria, I tried to eat, I hope it's traditional dish, Spätzle mit Käse. Ist das sowas Österreichisches, Typisches? Okay, it's like a kind of pasta with cheese, and I tried it. It was really delicious, but after the half of the meal, I couldn't eat any more. I think my mother, she warned me, if you go to Austria, I think their food is quite wie sagt man, so sehr sättigend.
Yeah, you feel very bloated after.
Yeah, and she was afraid I would gain too much weight.
I love your answer, Aman, because it made me think how, you know, in food, we all like, even if you're from one place, you may gravitate to another type of cuisine, and how, you know, the more food you try, you know, you kind of get to experience other cultures and things like that. And I see how this can like translate to clinical reasoning, how the more people we have in this community, the more we learn. And I recently went to this like art gallery, and there was like this painting that was supposed to evocate like how sometimes when we think about, you know, trying something else instead of sticking to our culture, or translation, how we may lose things in translation. But the artist was trying to advocate all of the opposite, the things that we can learn of like translation, the things we can learn from other cultures. And I had a question for Sammy, actually. I didn't even know you had started residency. Congratulations. Time moves so quickly. And I know that you have been in the States for a couple of months doing medicine as well. Is there like one thing you think people in the US can learn about how medicine is practiced in Germany and how, or like Austria, and how, and like, is there one thing that you think people in Austria can learn about how medicine is practiced in the US? What would it be?
Yeah, I think the second question is easy to answer. The first one, not so. But when I compare like medicine in Austria or Germany and medicine in the US, I went to the US for 4 months for rotations just to like experience all this teaching atmosphere. And also I got to know it through CP solvers, how you have teaching physicians, for example, rather sometimes on teaching service. And we don't really have that in Austria and Germany, and in Switzerland a little bit more, but that's something we are currently working on. And we have a young population, young generation of also now physicians that really want to work into that and optimize like medical education. We don't have resident reports every day, for example. We have that once every 2 weeks or something like that. It's a lot of you have to do a lot on your own if you really want to improve. That's maybe something that the education is, in my opinion, a little bit better in the US. It depends where you are always, but as a rule of thumb. And when I think about what the US could learn from Austria, I don't know. When I was in the US, I felt like it's not too much medicine, but it was a lot of waste. You know, when you went into the cafeteria, everything was plastic. In Austria, you don't have that. That's maybe not medicine, but I was just thinking, how can you produce so much waste when even in the hospital, you know? That was something that I noticed. But apart from medicine, I don't know if I have anything else to add. I don't know, Leah, Shema, do you have any other thoughts?
And I love that, Sammy, that, you know, it sometimes we separate those things in our minds, like medicine and non-medicine, but they're so intertwined. And I think one of the things that like I can try to like amplify from it is really like the quality of like how I think sometimes in Europe, the food is a little bit more appreciated than in the US, and that can like correlate to like how things are presented, what type of food do you eat, and like how much time do you have for lunch and things like that. So I think it's interesting, you know, medicine and non-medicine is like very blurry. Shema, Leah, Anita, anything else to add to Sammy?
I was going to add something about a question that was being asked in the chat about what kind of museums you have to visit when you're in Germany. So I am citing my former Latin teacher. She used to say, if you're a student and you're here in Berlin, you're very privileged because you can go so cheap into museums. Like, I think it's like, and on some Sundays you can even go there for free. And if you're here, like you can go to the Naturkunde Museum, the Old and New National Gallery, and yeah, so much. You can discover so much. And also you can visit the Botanic Garden. And regarding the food, I mean, I know there is typical German food, like we say potato. That's actually true. Like when I went to school here, we almost had everyday potatoes. I love it. But there is no typical Berlin food because Berlin is such a clash of so many cultures. Like where I live, we have like Italian, Vietnamese, Turkish, restaurants from Morocco. So it's a clash of so many cultures, and also Indian restaurants. So yeah, and döner, I mentioned it. You have to eat it here. Please do it. And there's also a vegan version. And Leah?
When actually thinking about food, I think that's common in Germany and Austria. I think we have really good bread, like dark Schwarzbrot oder Bauernbrot. If you Google that, then you'll find something. And I'll give the baguette to the French, but if you have real dark bread, then you have to go to Germany or Austria and try that.
I love it. And I was actually gonna ask Anita that she told us she wasn't originally from Germany, but I also agree that Germany feels like this very multicultural, multi-linguistical, like everything. And Anita, I was wondering, are there any reflections on how have you adapted to practicing medicine or living in another country? How has this felt?
I think right now I'm quite well adapted and integrated. I can actually apply for a German passport quite soon. But initially I was like, I arrived here to like sort of an international class. It's like a foundation year that you spend with a lot of internationals. We had a lot of people from Latin America, from a couple from Colombia, like everywhere from Latin America that wanted to move to Germany and study here as well. So we were all getting like our school education up to the German standard. So my integration was very fluid, like it was very soft. And I was like, I spent a year in this international community, and then I started uni. And in uni, it's like we speak only German, and there are like a lot of Germans from all over the place. So I think starting uni here in Berlin was very easy to me. But the fact that I started in an international community and I live in a very like multicultural city, which Berlin very much is, has played like a very big role. If I would go somewhere, someone mentioned Jena as an example. Yeah, I think like I don't know any other German city that is so multicultural as Berlin.
That's amazing. It's glad to hear that you've adapted well, and how I can't even imagine such a multicultural hub in one place, and except VMR maybe. I really appreciate everybody staying here for a couple more questions, and I want to be respectful of everybody's time, especially on a Saturday. I really appreciated everybody here. I learned so much, especially from Shema, Sammy, Anita, and Leah. They've taught me so much over the years, and now I can add Nicola to my friends, my German friends who've taught me so much. I want to end this session with just one question. I really want to highlight Shema. She was the first person I met from this side of the world, and we came up with this idea of translating schemas to German, and I left the idea in her head, and she came back a week later with the whole team, 100 schemas translated, the website up already, and she was like, here you have it, it's just the beginning. And I was like, the beginning is amazing. I can't believe how fast and how hardworking these people are. And honestly, I think Shema has been like a great leader. And in my eyes, she has always exemplified a lot of the values that we appreciate in VMR. Shema, how has this experience felt for you? You know, being the leader of such a fantastic group of people and doing all of the things you've been able to do over the years.
I have to say, I've never ever seen it like kind of any leader thing, because it was really a group work. I also really want to highlight, you know, Sammy, Leah, and Nita. We put so much effort in this project. Like the whole project would have never been the way it is now without any of them, you know. Leah already also sent me so many new schemas that I still have to upload. I'm so sorry, I'm still back behind, but you can see it's such an amazing work with this amazing team we have. And yes, it wouldn't be the way it is without any of them. So thank you so much to all of you.
Thank you, Shema. We'll plug it in one more time if you want to practice your German and check the schemas. And thank you so much. Lots of love for all of you. I was trying to think of the German translation, but all of my years of studying have failed me. So maybe, Leah, do you want to say goodbye in German and wrap this up?
Yeah, sure, I'll give it a try. Und ich freue mich sehr, dass ihr heute zugehört habt, dass ihr dabei wart. Es ist jetzt schwer zu sagen Tschüss oder auf Wiedersehen. Es gibt viele Arten und Weisen, wie wir uns verabschieden können. Aber ich werde sagen, bis zum nächsten Mal, weil ich hoffe, dass es nicht das letzte Mal war, dass wir uns gesehen haben. Und wünsche euch noch einen schönen Abend. Wenn ihr in Österreich, Deutschland seid, dann jetzt Abend. Oder wenn ihr es euch später anschaut, dann was auch immer für Tageszeit ihr habt. Tschüss, bis zum nächsten Mal.
Tschüss.
Auf Wiedersehen.
Bye.
Bye.